Welcome. Dr. Andy Looney, a boarded anesthesiologist, partnered with Humane Alliance to review our anesthetic protocols. We strive to always meet current guidelines and recommendations, and we're sharing updates to our protocols today. Welcome, Dr. Looney.
Thank you, Amy. Thank you, Melissa. And hello, everyone. I'm here today to tell you about some changes that are occurring in Humane Alliance anesthesia protocols, what is changing, and why those changes are occurring. And you might ask why I actually care about shelter medicine. Following my residency at Cornell, I ended up taking a position at the MSPCA in Springfield, Massachusetts, under the direction of Dr. Rhea Morgan, who was very instrumental in pointing me in the direction of shelter care. So I obtained a great deal of ground experience in an inner-city shelter, really enjoyed it, and had a great interest in the pain management and anesthesia of these patients. And this led, of course, to a connection with a lot of the shelter individuals known nationwide. And we put together our first document, the Association of Shelter Veterinarians Spay Neuter Programs Guidelines. Much of that document focuses on anesthesia, and I was very fortunate to lead that group. There's a newer edition coming out very shortly, including a few more anesthesiologists and spreading the workload and involvement of many different folks, so it'll be a great document. The protocols at Humane Alliance are changing for a number of reasons, probably the biggest of which is cat and dog anesthesia standards have changed over the last decade, and we need to keep up with those. Evidence-based medicine, or EBM, really forces us to change that, and sometimes we're in favor of it, sometimes we're not. But we really need to look at the science behind these changes and start to follow that in our daily routines. Humane Alliance is what I call a near academic model, meaning that they do an awful lot of training and a great volume of practical experience is joined with that evidence, and we really need a regular reevaluation of anesthesia protocols, typical of what you'd find in any practice. We also have a number of problems in national back orders and recalls, which force us to maintain some type of consistency in this face of a changing supply. And certainly there are cost considerations, but I want to make it clear that these are not cost considerations that are absolute. It's the fluctuations in cost overall for shelter operations that we want to try to level out over time. And we certainly want to try to minimize our use of compounded medications. There is a need for those in our profession, an appropriate need for the individual patients, but when we deal with a volume of patients that many shelters deal with, certainly we want to try to stick to products that are well tested and well researched, usually having larger companies behind them at this time. These are the standards that we're going to be referencing today, and if any of you need to get online and Google these, the PDFs are freely available. They are quite thick documents, so I warn you before you print those out. But the AHA and the AFP guidelines, the WASAVA guidelines done by Carol Matthews, just great documents to help us better understand about what we should be doing for our patients, whether we're in specialty practice, private practice, shelter operations, industry, or research, when we anesthetize our small animal and large animal patients. So I'm just going to talk about an overall changes that we're doing for our CAP protocol today. The original CAP protocol for Humane Alliance combined medetomidine with dexmedetomidine, two pretty potent, what we call alpha-2 agents. And this theoretically made very little sense. We did it for a cost basis initially, but with compounding issues, we decided to just stick with one of these drugs. Certainly, the buprenorphine that we initially used in the combination, theoretically a great analgesic for cats, but practically speaking lacks some sedative characteristics that really need to help us process quickly a large number of patients. The original protocol also spoke about reversing with a drug called atipamezole. And while this possibility exists for the individual patient, the overall reversal of many patients probably was not in their best interest in ideas of returning both stress plus or minus pain to those patients. And probably our biggest difference is that we really wanted to try to avoid masking with isoflurane. Masking was done in a large number of our patients initially, and this is really in no one's interest. It pollutes the environment for staff and certainly provides a rather unregulated way to increase inhalational anesthesia in our small animal patients. We have better ways to do that nowadays, and we want to minimize that stress to the staff as well as what we call workplace pollution. And our biggest change will be the use of a non-steroidal, and we really want to try to encourage this in every case. We want to encourage it being given as soon as possible, and the evidence has come around for that. So these are our changes in the cat protocol we'll be speaking about. In our dog protocol, the original dog Humane Alliance protocol used a number of great agents, but we're really trying to dose those agents more specifically based on metabolic rate and lean body mass. So we're trying to fine-tune a little bit of the dosing, extremely important for our non-specific agents such as acepromazine and ketamine. Many of you know that acepromazine is a drug that's capable of some vasodilation, and we want to minimize the size of the spleen in many of our canine patients as you enter the abdomen to certainly avoid causing any hemoabdomens. Buprenorphine is an analgesic used in both small cat and dog veterinary anesthesia. It's a pain reliever. Its suitability is much more prone for the feline population. So for our canine population, considering the cost and the vials and the volume that we would use for our dogs, they're probably more suitable analgesics. The original Humane Alliance protocol used sub-Q drug administration, and what we found with this is that, typical of any anesthetic agent, subcutaneous administration is probably not the best thing to do when we deal with vasoactive drugs, as the subcutaneous depot really can shut down rather quickly as these drugs start to get on board. So what we're finding with sub-Q administration in our original protocols is that patients slept with acepromazine given subcutaneously, but unfortunately not around the time that we needed them in about 30-40% of our patients, and they slept for a long period after when we needed them to wake up. So we are going to try to minimize that drug and administer it another way. Tachycardias, we obtained quite a few of those in our canine population with the original protocol, and what we're finding in our profession by and large is that if we go ahead and tolerate a normal cardia, meaning a normal heart rate, or even better yet, a bradycardia, a slower heart rate, we have better perfusion for our patients. And this is our idea of limiting both the acepromazine and the ketamine amounts given to each individual patient. So our new protocols look somewhat like this. Our feline protocol being a combination of 3 drugs, dexmedetomidine, tilazol, and an opioid, and we're choosing morphine at this time, and a non-steroidal, which we're choosing meloxicam. Our canine protocol being a combination of acepromazine, morphine as a pre-med, and ketamine and midazolam or diazepam as an induction agent, and Medicam given to those patients in addition. You notice we are not going to be reversing our canine patients, very little need for that, and really no reversal agent existing for acepromazine and or morphine. But our feline patients, we can consider reversal in that group with a dose of antecedent, plus or minus a small volume of saline to make that dose of antecedent a little more appreciable to the patient in order to get that on board and circulating well. So I've talked in general about our changes in our protocols for Humane Alliance anesthesia drugs, and now I'm going to get into a little bit more of the nitty-gritty of those changes in terms of the drug choices, the routes we're giving, and some procedures around the anesthesia experience for our patients. I'm going to show you a little bit of evidence behind these changes, too, to try to elucidate why we're making those and where that evidence is coming from. So the first change I'll talk about in specific is our feline drug protocol. And I mentioned that it's going to transition from a combination of medetomidine and dexmedetomidine with ketamine and morphine to a product called telazol. And telazol in and of itself is a combination of taletamine and zolazepam. We're going to combine that with dexmedetomidine and an opioid of your choice. The opioid we're going to choose currently is morphine. That can change over time depending on national availability and also depending on the type of anesthesia you'd want for your patients, whether you'd want a more profound sedation or a little bit more of a short duration procedure. It depends on the volume of patients and your staff familiarity with the agents too. This change really eliminates the use of the compounded medetomidine. We have a drug called dexmedetomidine, which is actually one of the isomers of medetomidine, considered now pretty much a standard of care when we talk about alpha-2 agents. Overall, the use of this combination is a tiny volume of injectate, and that's very important when you deal with a large number of patients, when they're small patients like cats and small dogs, and we certainly want to avoid any massive IM volumes being injected in these patients. This has been published as a very suitable option for high-quality, high-volume spay and neuter. If you Google Jeff Coe, he's a fellow anesthesiologist who has done a lot of work in this area with these combinations. He's done several different publications, which we'll go through in a minute, and certainly is a great resource for looking at all the different combinations with telazol and dexmedetomidine and different opioids. So keep his name in mind as we go through this. Certainly, this combination, when we deliver it IM, really anesthetizes the patient very soundly and safely. And what this does for us is requires less use of an inhalant agent. And ironically, isoflurane or sevoflurane, in a recent study published by Rick Broadbelt, has been considered a risk factor for morbidity and mortality, M&M, in small animal anesthesia. As crazy as that sounds, several decades ago we would have hung on to that as a agent that actually helped us safely guide through anesthesia. Now we know that it's being considered a risk factor if we minimize the use of that, especially if we minimize the use of that delivery by mask. We are not only helping our patients get through anesthesia safely, but we're helping our staff cope with anesthesia safely. And these are some of the changes in terms of that feline anesthesia protocol, the evidence behind them. Notice that in several of these publications, we're looking at the word of dexmedetomidine in combination with several different agents. And I bring these to your attention because dexmedetomidine really is considered a quality agent to produce sedation, analgesia, muscle relaxation, and loss of anxiety. Those are 4 sound anesthesia characteristics that we want to have in any anesthesia protocol. So this agent is really a basis for that. Some folks have considered whether this agent is actually safe for all patients. And there are some patients that this agent probably should not be used in individually based on either cardiac disease or on renal disease. But overall, this agent has been studied in terms of both of those problems, cardiac disease specifically in cats and in dogs, and renal disease in cats and in smaller lab animals. And these are just some of the papers that will help produce some quality evidence when you start to look at how this agent actually can provide for sound tissue perfusion despite its bradycardia. And the bradycardia is a big worry in many individuals who haven't used this agent. So if you're new to this agent, I would suggest you look at some of these, and we are working to get several of these on a website in PDF form for you. But there is evidence out there to suggest the safety and the soundness of the use of this agent in feline protocols. And again, probably one of the biggest studies and researchers in this area is Dr. Jeff Coe, K-O, and he's done a number of quality studies about this agent in the shelter setting. So really nice to have that on our side. The second change in particular I'd like to speak about is the canine protocol. And we mentioned that acepromazine has been an agent that Humane Alliance has used in the past and has had success with. Some of the issues we've had with that agent have been the vasodilatory problems caused by splenic enlargement and prolonged sleeping. So what we've done is we've actually dosed this agent a little more appropriately based on lean body mass and body size. We're going to maximize the dose at 1 milligram regardless of the calculation. And for our smaller patients, realizing that although we don't have a registered product, a dilute acepromazine product in our veterinary profession, we can create a dilute acepromazine. And this allows for a more accurate dosing for our tiny patients. Also in our canine protocol, as canine body weights increase, we're going to try to limit that tachycardia we spoke about, and we do so by minimizing our ketamine doses at our very large body weights. We don't want to increase and encourage tachycardias, forcing some of these patients into possibly an AFib or an atrial tachycardia situation. We're going to make up the slack for that by increasing our midazolam and diazepam doses. And the benzodiazepines, midazolam and diazepam, are considered what I call very benign fillers to our anesthesia protocol. They are very, very safe, and they provide a nice safety net for our patients in terms of mixing with other drugs. But in and of themselves, they don't provide for a lot of quality sedation. So we do need to combine those agents. I think we've done so rather nicely in this protocol. This is some of the evidence to consider in those changes. We look at our canine evidence base. We have an awful lot of that over the last decade and a half. We're getting more evidence in our feline base, but acepromazine is actually a quality agent. And we're not going to lay dexmedetomidine in the forerunner place for all of our patients. We know that acepromazine is still a very good agent. In fact, has great properties as far as antiemetics, antihistamines, and certainly a quality permissive effect, meaning that vasodilatory effect helps to carry the agents, the other agents that accompany it, where they need to go, such as morphine, such as ketamine, such as diazepam. So this is the evidence to support that. The third change I'll talk about in particular is that we're going to be using a nonsteroidal on all patients, regardless of species or age. The evidence has come around even within those guidelines, despite the black box label in meloxicam, the guidelines clearly stating that the use of nonsteroidals should be considered in cats perisurgically and even long-term. So that's a 180 degrees reversal from what we had about 5 years ago. Meloxicam is the agent we'll be using. This eliminates the necessity of using a postoperative buprenorphine dose, such as was used in our original HA protocol. And the most important aspect of this change is that we are giving an anti-inflammatory to every patient. Opioids and alpha-2 drugs, such as dexmedetomidine, do not provide for anti-inflammation. So we need to provide this with an anti-inflammatory of sorts. We can choose any. We can choose a nonsteroidal. We can use a steroid. We can use a local block. We can use even certain modalities such as laser and cryotherapy. But it's important, based on those guidelines, that we address inflammation. And folks, here's a key fact. It's even more important nowadays because the overuse or the unopposed use of opioids without these drugs may actually increase inflammation. Isn't that crazy? We're finding that opioids alone can increase inflammation and even further can increase some forms of angiogenesis and tumor metastatic disease. So we need to use an anti-inflammatory in our protocols. I think that's going to be important for you guys. For our feline patients, it's important to note that we're using 1/3 of the manufacturer's original labeled dose of meloxicam, a 0.1 mg per kg dose. And this can be administered subcutaneously or IV. We're choosing to give it subcutaneously. In patients where you worry about their renal perfusion, you can always give a small dose of subcutaneous or IV fluids during surgery. But this dose is considered very safe in our feline patients. And the evidence behind that has been around in the canine world for a while, but in the last 7 or 8 years has really blossomed for the feline population almost as a result of that original black box label for meloxicam. We've seen studies that have looked at not only the use of meloxicam in the average patient, but in the patient where hypotension and hypoxia have been an issue, and not only given intra-op and post-operatively, but given pre-operatively in those patients. And I'm going to take it even one step further. The evidence is actually out there to show the use of these agents not only given pre-operatively to patients with some type of cardiovascular compromise, renal compromise, but also given long-term, so within days to weeks after the surgical event. So we have a good degree of safety out there in our anesthetic protocol that we're changing to. And I would again suggest Googling some of these studies. Several of them have been so well documented and so perused by our human counterparts, our clientele, that they are actually available online without academic license. So we're working to get several of these up and ready for you. But a couple of these I'll look at on this slide, looking at the use of the meloxicam and some basic baby aspirin, acetylsalicylic acid, in cats with reduced renal mass, surgically reduced renal mass, given at the time of surgery and given postoperatively. Looking at the use of meloxicam in cats with overt chronic kidney disease. Looking at changes in their creatinine clearances, PCVs, liver enzymes, pre- and postoperatively, and finding no changes. So the key use here is that we are using this in a large population, mostly healthy. We are using this at a lesser than labeled dose, a 0.1 milligram per kilogram dose, and we are trying to get the drug on board pre-scalpel laid to skin, so pre-incisionally. So we are adhering to the guidelines of preemptive administration of this drug. So I suggest looking at those for just support in making your changes. The fourth change I'll speak about is one about feeding our patients or limiting fasting, especially important in small animals, small cats, small dogs, and especially important in two other classes of our patients, pediatric, neonatal, and our geriatric patient. Now, this might seem in contrast to the fasting we've previously recommended, but recent research and standards have really looked at this closely, and much of this work has been done out of the veterinary colleges and institutions in Europe, especially in Greece. And looking at these changes that we've made, what we're finding is that if we go ahead and limit fasting or feed our patients a little bit preoperatively, usually with 2 hours ahead of surgery, 1 to 2 hours ahead of surgery, we can limit key items of problems in surgery, and those are regurgitation and vomiting, intra and post-op. We call that gastroesophageal reflux during anesthesia. And number 2, we can limit those drastic changes in blood pressure and heart rate that we see in some of our tiny patients. Many times our pediatric or neonatal patients, we fast them for the average of 4 to 6 hours, and that's a long time for them. They don't have the reserves, hepatic-wise and body fat-wise, to draw from, to keep their blood sugar up. So what happens is their stress enzymes kick in, and we see those changes under anesthesia in terms of tachycardias, bradycardias, sometimes even worse in terms of cardiac arrest. Hypotension and hypertension being very common changes with them. The gastroesophageal reflux is a huge issue in terms of the dog and its problematic consequences with esophageal stricture formation post-operatively. And you wouldn't think that little bit of reflux would have such a huge effect. But what happens is when the animal is in recumbency and they get that reflux, and ironically, they get that from prolonged fasting, more than 6 to 8 hours. What happens is that reflux sits in the esophagus and creates a lesion. And that lesion postoperatively strictures down, and that is a life-threatening problem for these patients. So if we can go ahead and limit our fasting in these patients, we can avoid that life-threatening problem. And our spay-neuter guidelines, our first guidelines that were out in 2009, 2010, reflect this, and our newer guidelines will keep this same recommendation, is that food should be withheld for an appropriate time prior to surgery. What that is for our smaller patients is they should be fed 2 to 4 hours before surgery. And we don't need to feed them a huge meal, but we should give them a little something, certainly not withholding water at all, and making sure that we try to minimize the fasting if we can to a 2 to 4 hour period in those tiny patients and in our geriatric population as well. There may be some patients we can't limit that fasting for, such as obese patients, such as those that have a foreign body and are chronically regurging. But certainly we want to go ahead and try to allow a small snack prior to those pediatric patients coming into the hospital. The fifth change I'll talk about in particular is, again, I mentioned the use of an anti-inflammatory around the time of surgery. This can be a number of medications and or therapies that we can give, but it's important to provide an anti-inflammatory effect in the face of using opioids nowadays. And what we have chosen to use in place of meloxicam for our brachycephalic patients is a drug called dexamethasone sodium phosphate. It is a steroid considered to have more potency in treating upper airway distress if this patient subset gets into problems, and certainly more helpful in reducing inflammation both laryngeal-wise and cerebral-wise should airway obstruction occur. A minor change in my mind, but a very important one for those patients that are considered brachycephalic. And I want you guys to open your mind when you think about this. Think about your Burmese and your Persian cats in addition. Certainly think about Shar-Peis and Chows being in that population in addition. What we know about these patients is that outwardly they may not have that type of smushed face or prognathism that the other obvious breeds such as bulldogs or boxers have, but inside the redundant tissue really creates a brachycephalic environment. So try to widen your window on what you think about in terms of a brachycephalic breed. The sixth change I'll talk about is the use of the drug antecedent. And antecedent is a reversal agent which will reverse the effects of dexmedetomidine. Initially in our protocols, we use that very regularly, but in our current protocol, we'd like you to question whether you need to administer this or not, bearing in mind that the reversal can bring about anxiety, increased sympathetic tone, and plus or minus pain. There's been some good papers out recently to show that the pain aspect of dexmedetomidine may be protected when the antecedent is given. But I want you to really think about whether we actually need to administer this agent or not. Certainly there are some patients, if they've slept for longer than 45 to 90 minutes, we can go ahead and reverse them. Maybe you have a crowded recovery area and you need some more room. So certainly the possibility exists, but try to use a plus or minus in your mind about whether you need this. The final change I'll speak about is performing extubation a little bit earlier in the recovery process. And in particular, in patients that are prone to laryngospasms, such as cats and brachycephalics, we really want to try to avoid leaving that tube in until the animal gets that true gag reflex, feels it, and jumps up and hops away, very upset. What we are doing is evaluating the patients when they are in recovery for appropriate palpebral response and jaw tone. Certainly we have waited in the past for some tongue tone to be present or a swallowing reflex. We're no longer doing that. We're really trying to establish whether they have minor cranial nerve function, allowing us to go ahead and pull that tube. So they don't have to have a swallowing reflex. And again, our rationale for this has come around full profession. We're trying to avoid a sudden arousal, anxiety, and gag reflex. There are some patients that you want to keep the animals intubated as long as possible. These are the obese patients, those patients that have a full stomach, maybe ate within an hour of surgery, patients with foreign bodies, certainly patients with esophageal and thoracic surgeries. I hope you won't be doing too many of those in a shelter setting, but keep that in mind. This can be a qualitative change. Amy, I'm going to turn it over to you for a moment here to talk about the dosage charts on the e-learning site.
Yeah, thanks. And so we know that Andy's given a lot of great information here, and it's a lot to take in. So we have made it available on our Humane Alliance site. So if you go to humanealliance.org and go under e-learning, which we've marked over here on the right, you're actually going to go under the medical tab next. Then you're going to go under prep and recovery. You'll see we've marked all these. And then you're going to go into our drug protocols. And that's where you're going to find all of these charts. So we have our canine drug log. We have our canine drug charts, our pre-med charts. We also have feline drug logs and charts. We have a dysphoria chart. And this is where we will also be putting a document that has the evidence behind the changes. So all of those different studies that you saw will be listed in a document, and we are working on getting PDFs to put up in this location on the site as well. So humanealliance.org will have all of what Dr. Looney has talked about here today, and also a recording of this webinar.
Great. Thank you, Amy. And I'll just summate the changes we've made in the anesthesia protocols. Again, we've made these changes because we're trying to address the recent standards that have surfaced in veterinary anesthesia. We are trying to stick and adhere to the multimodal and preemptive analgesia foundation that has been laid in our profession over the last decade. We're trying to provide an increased safety for our patients as well as our staff in minimizing that waste, pollution, and inhalant anesthesia. We're certainly upholding both practicality because we realize that your job every day deals with volumes of patients, unlike the average practice, and certainly appreciate the schedules and the workflow that you have. We want to try to minimize our liability, of course, but we want to stick to standard FDA-approved products. And this is going to become more important as national back orders surface throughout the profession. So overall, these are the changes that have been made, and I want to say thank you very, very much to both Amy and Melissa for being here with us today and recording this. These are some of the general references that I think you might find helpful. Dr. Jeff Coe and Dr. Sheila Robertson have written some great chapters on this. I've written a couple of references myself, and hopefully you'll find them helpful as you evaluate your own protocols and possibly move forward to changing them. Thank you very much, and goodbye.